Alright, this video shows the diagnosis and treatment of GERD. Actually, it all depends on the symptoms. On the left, if you have patient without alarm symptoms, typical symptoms or atypical symptoms, usually you start with a PPI trial, and there's no need to over-treat the patient. Just use once daily dose for 8 weeks. If this doesn't give you a good response, you can just double the dose with the PID dose for another 8 weeks. If the patient doesn't have any response with the double dose for 8 weeks, you go ahead and do an AGD for the patient along with a esophageal biopsy in order to rule out other etiology. On this arm, you have patients who have alarm symptoms and patients with chest pain. First of all, patients with cardiac complaints, you should make sure that their cardiac status are okay. Recently, the ACG have suggested doing an AGD prior to PPI trial, yet some experts still use a double dose VPI before that if they have the cardiac condition cleared. Whenever you have alarm symptoms, you just go ahead and do an EGD with esophageal biopsy in order to rule out any other etiology like eosinophilic esophagitis, because the dysphagia is alarm symptom. As we reach the point of doing an upper endoscopy, the results of this endoscopy will tailor the next step. If you have GERD, Los Angeles classification A or B, you can go ahead and give once daily dose for 8 weeks. In case you have C or D mainly, sometimes they give double dose for the B, but usually we give it for the C and D Los Angeles classification, or GERD with parrots, you give a higher dose for 8 weeks. Once you complete the 8 weeks dose for GERD B, C, and D, you need to have a repeat EGD to assess the healing and the possibility of parrot esophagus. In case these patients with the grade A and B don't show enough response, you go ahead and double the dose for another 8 weeks. Those responding patients with grade A and B, they can give on demand PPI, while usually patients with the more severe GERD, they require indefinite PPI. In case of both, without enough response, you should look for another diagnosis or check the compliance of the patient. We will stop at this point and move to the other arm with the patients who had normal EGD. If your patient doesn't have dysphagia, you just go ahead and the next step will be checking the acid pH monitoring of this patient. If your patient suffer from the dysphagic symptoms at some point, you might need to do an esophageal manometry before the moving forward with the pH monitoring. Alright, as long as at this point we reach the pH monitoring step for both arms, I need you to bear in mind that this side, these patients, you already have your diagnosis. They have GERD, they have evidence of GERD on the EGD, yet you don't know or you don't understand why these patients are not responding. While on this side, these patients do not have the evidence of GERD on their EGD, so you still don't have the diagnosis in hand. Anyway, for both of them, you need to check the acid secretion. But while you have the diagnosis in hand here, when you do the study, you do it on PPI treatment because you have a diagnosis. while in the other arm you don't have the diagnosis in hand, so you need to check the study while the patients are off treatment. Alright, so it's either if you do the pH, the regular pH monitoring, or combined with impedance. The results here will tell you what kind of condition you're dealing with. Here on the left you see that we have these variables, the acid exposure time, relation between the acid reflux episodes, and the symptoms index. If you have someone with a normal appearing esophagus while still have symptoms of acid reflux, after the pH monitoring, you have one of these three possibilities. Either the patient don't have increased acid reflux, or they have abnormal acid reflux. Abnormal acid reflux is defined by finding a pH less than 4 for more than 4% of the time of the study. The other variable here is the presence of good relationship between the reflux episodes and the symptoms. If the patients do not have increased acid in the study, that means the pH is more than 4 or at less than 4% of the time, while they still have good relationship between the symptoms and the reflux. These patients are defined as patients who have hyper sensitive esophagus or functional heartburn or chest pain. When you have a normal acid or index, symptom index for the acid and non-acid, that means that when you divide the symptoms with reflux on the total number of symptoms and multiply it by 100, give you a percentage. If this percentage is less than 50%, that's normal. So when this percentage is above 50, that's abnormal. So if you have good relationship with normal acid, normal symptom index, that means that you have functional heartburn. If you have increased acid production, positive symptoms index, that means that you have NERD, you have non-erosive reflux disease. If you have none of these, I mean you have normal acid study, you have poor correlation between the symptoms and the episodes of reflux, that means that you have something else you're dealing with. And these are the least number, the least number you're gonna get usually. As most of these people, when you study them, mostly they will end up with the result that they are functional. On this side, what's the management with these three findings? Patients who have functional disease, usually they don't respond to PPI, and usually these patients are the most common reason of PPI failure. You go ahead and you try antidepressants or SSRIs on those patients. The next category, the patients with NERD, these patients do respond to PPI, yet they respond less than patients with erosive esophagitis, and usually they are not dose dependent, is that they benefit more from longer courses rather from higher doses. If these patients do not respond to your PPI, you might go ahead and consider the surgical option here. The third possibility, patients who have poor correlation between the symptoms and negative acid study, this patient would never respond to PPI nor surgery. You might, to review your diagnosis, you have to rule out other diagnoses like achalasia by doing manometry, rule out gastroparesis, bile reflux, and other functional disorders like functional dyspepsia. And the other arm here, the patients who had already evidence of GERD, when you do the study on PPI, you have one of two possibilities. Either you have a high acid reflux, or you have a weak acid reflux. Weak acid reflux means that these patients have non-acid reflux. We define those patients who have acid reflux on PPI that they have refractory GERD. One step you may go ahead and try is adding H2 receptors agonist, H2 receptor blockers at the QHS time at night time. If they don't respond, you might consider a surgical fundoplication. Patients who have non-acid reflux, you need to stop giving the PPI because there is no benefit of the PPI. You go ahead and try the baclofen. Baclofen decreases the frequency of transient lower esophageal relaxations. If these patients also do not respond to your management, you just go ahead and consider the surgical option again. A few words about the pre-op management. Usually all the patients pre-op they need manometry. You have to do that to rule out achalasia or scleroderma because these two are contraindications to fundoplication. While pH monitoring usually is required for patients who never had an evidence of GERD on their EGD, we mean NERD here. Okay, a few words here about the clinical course of the reflux disease. These are repeat of the three possibilities we had here at the top for the patients with NERD. We're not going to discuss this again. Just a few words, because sometimes they give you on the board few questions about these, that you need to know that like 70% of people who are referred for EGD for reflux symptoms, usually they have normal findings. And also manometry, usually 70% of these patients have normal EGD manometry. About the erosive reflux disease, which is represent 20% only of the patients, usually without maintenance treatment, 85% of these patients will have relapse within 6 months. So most of these patients will need maintenance therapy. Just keep in mind that GERD grades C and D, they harbor from 10 to 20% parrot in the esophagus. About the refractory GERD and the rule of PPI failure, we have here a couple of causes that cause the failure of PPI. Functional chest pain and heart pain is the main reason or etiology behind failure of PPI. You might encounter other problems or etiologies that lead to this failure. Is the incorrect diagnosis, like you have Bile esophagitis, you have missed it, eosinophilic esophagitis, scleroderma, use of NSAIDs. Additional diagnosis that you might not have diagnosed yet, like dyspepsia, and not also dyspepsia, celiac disease, gastroparesis, or inadequate acid suppression, most commonly due to non-compliance of the patient. Other post-operative problems like partial gastrectomy or band gastroplasty, they may lead also to the failure of the treatment. Also free regurgitation like absent of LES tone, large hiatal hernia and achalasia and rumination syndrome. All these leads to failure of the PPI treatment, yet the most common cause still the functional disorders. I hope that helps.